Members, good morning. It's the appointed time. We have a quorum. We have quite a long agenda. Originally from 10:30 to 12:50. But then we have VIPs for lunch today. So at 12:45, all of the members should go to the lunch. I will manage to time tightly. I do not want to leave out the co-care scheme. So I will manage to time well, and I want members to cooperate with me. We aim to finish the meeting at 12:45. Thank you, members, for your understanding. Since last meeting, the Secretariat has not received any information papers. For the next meeting, we will discuss the following items. The next meeting will be held on the 13th of October, Friday, at 10:45. The administration proposed to discuss review of fees and changes under the purview of the Department of Health and the redevelopment of Shakip-May Health Center. Any comments from members? If there is none, we will discuss these items in the next meeting. Agenda item number 3. The proposal to conduct a duty visit to the University of Kong-Shenzhen Hospital and hospitals of Tier 3 Class A in the Greater Bay Area, GBA. Mr. Kingsley Wong, please walk us through your proposal. Then we will invite members to comment. Thank you, Chairman. As I mentioned in the paper, it is difficult for patients to have consultation and treatment in the public healthcare system. Medical professionals are under great pressure, so just relying on Hong Kong alone cannot solve our medical problem. We should explore room to have consultation and treatment in the Greater Bay Area. I have heard from quite a lot of members to support the principle of money following the patient. So I propose conducting a duty visit to the University of Kong-Shenzhen Hospital and hospitals of Tier 3 Class A in the GBA, as well as the dentist clinic. We need to see the situation in the flesh in order to have a better grasp of the situation in the mainland in relation to their medical levels to assess whether it is up to standard. That is my purpose. Thank you. Well, I forgot one thing. On the 29th of July, we will go to see the statistics about organs. I was informed by the Secretariat that Hong Kong currently has an organ donation scheme which cannot be carried across the boundary. If members have interest, as we have quite a lot of time in the GBA, on the 29th of July I will sign it myself as I need the QR code. Members do not have to sign it in advance, but should members want to sign the organ donation scheme, I can ask the Secretariat to give you the form. You can fill it in, and then I can bring your form to the GBA or the mainland, and I can submit the forms to you. Well, I didn't mention it at the start of the meeting. It's 10 days or 8 days away from the 29th of July. Thank you, Mr. Kingsley Wong's proposal. Any members want to speak? No? Then I'd like to ask members. Do members agree to the proposal? Can you raise your hand? Anyone against it? All members support it. No members abstain. So members are in support of this proposal. The Secretariat will prepare some documents about the scope and the details about the duty visit. Members can consider the details. Do we have to wait until the House Committee resumes in October? Mr. Kingsley Wong, when do you intend to have the duty visit? No any particular time as long as time allows. Do members want to visit the hospital as early as possible, probably in August or September? We have to liaise with the administration. Dr. Dennis Lam. Well, I think we should go as soon as possible. Mr. Kingsley Wong mentioned Tier 3 Class A hospitals in the GBA. When it comes to specialist clinics, there is no Tier 3 Class A hospital, given the very large scale. Hong Kong has different organizations or those in the mainland. I actually visited an eye hospital in Shenzhen of mine. Well, I have to declare my interest. It may be worthwhile to visit the eye hospital over there. Thank you. We can invite the Secretariat to follow up on this for us. If we can set off earlier, then we can set off earlier. But then we can also wait until the House Committee to circulate the documents. Thank you. Well, we have saved 15 minutes. Agenda item number 4. Update on tobacco control measures. There are 2 papers. CB bracket 4695/2023 bracket 03. That is a paper provided by the administration. The other one is CB bracket 4695/2023 bracket 04, the background brief prepared by the Legislative Council Secretariat. Let us invite the administration to join us. We have with us Professor Lo Chung Mao, Secretary for Health, Mr. Eddie Lee, Deputy Secretary for Health, Dr. Amy Chiu, Controller, Regulatory Affairs of the Department of Health, DOH, as well as Dr. Ying Feng, Head of Tobacco and Alcohol Control Office, TACO, of the DOH.
Good
morning, Secretary. As the items will also be handled by Secretary your good self, as we have VIPs to join us for lunch today. So all of the members will have to leave at 12:45. This meeting will have to end at 12:45. I will manage the time well. I'm not worried about you, Secretary. You have been very succinct and to the point. I have also invited my colleagues to cooperate with us. Well, the meeting is hosted by you yourselves, Chairman. Thank you. Let me introduce the update on tobacco control measures as well as the public consultation in this regard. Well, I believe that we all understand smoking is detrimental to health. 1 in 2 smokers actually die young. Secondhand smoke not only affects the smokers, but then it also affects the community as a whole. In 2021, smoking prevalence was 9.5%. Close to 600,000 daily cigarette smokers. 1 every 2 smokers is aged 50 years old or above. Aging population plus this factor actually impose tremendous pressure on the public healthcare system in Hong Kong. So we have been taking a multi-pronged approach in order to protect the health of citizens in relation to tobacco control measures. In the policy address in 2022, the Chief Executive set the aim of reducing the overall smoking prevalence to 7.8%. Statistics show that against the backdrop of aging population, female smokers did not decrease. Instead, they increased. Over 7% of secondary school students tried smoking. So there is a sense of urgency to put in place more effective tobacco control measures. This Wednesday, that is the 12th of July, we have initiated the public consultation of tobacco control measures. We mentioned 4 visions: vibrant, healthy, and tobacco-free Hong Kong, to reduce diseases and death, to protect the next generation, to protect the public against passive smoking. And we also need to reduce the burden on the healthcare system due to smoking. We have tapped the pulse of the community in order to decide on the way forward. There are 4 strategies. 1. Regulate supply and suppress demand. 2. Ban promotion and reduce attractiveness. 3. Expand no smoking areas and mitigate harm. 4. Enhance education and support cessation. The relevant papers have been annexed to the papers provided by the administration. We welcome members to air your views in relation to the next stage of the public consultation. I'm glad that 2 years after the public consultation started, there is widespread discussion in the community. Not only on radio channels, radio programs, we have received from different walks of life their support for the tobacco control measures of the administration. We have also received very constructive and encouraging opinions for our family members and the next generations. We invite the community to take part in the survey to air your views. We also want to canvass members' views in order to decide on a way forward in relation to the next phase of the tobacco control measures. Now, a couple of members have pressed a button to speak, a total of 6. Mr. Edward Leung, Chen Kim Po, Professor Chen Wong Kwok, Yang Wen Kit, Xiu Ka Fai, Chen Ho Yen. Mr. Edward Leung, 4 minutes. Thank you, Chairman. I support the general direction of tobacco control measures. When we put in place a series of measures, we need to better protect the health of non-smokers. This has been taken care of well. According to the papers, Hong Kong is an international city. Will very extreme measures affect our international standing or status? These measures do not just target locals, but also non-locals. Will it affect our reputation as a tourist attraction? If we ban non-conventional tobacco products, heat-not-burn products, as well as other conventional products, when non-locals bring heat-not-burn cigarettes in Hong Kong, nor can they buy any fruit-flavored cigarettes in Hong Kong, this will also undermine their experience in Hong Kong. I'd like to see whether there is any assessment in this connection. That is my first question. Apart from tobacco control measures, on smoking cessation services, we also need to enhance our services. Have you considered relevant measures? For example, in Singapore, some citizens actually receive a one-off coupons or tax reduction after they have successfully quitted smoking. Do we have similar measures? Thank you, Secretary. Thank you, Chairman. We have to move towards a vibrant, healthy, and tobacco-free Hong Kong. That is a healthy image of Hong Kong. We do believe that tourists may carry these items when they enter Hong Kong. In this regard, we have disseminated the information to airlines. On inbound flights to Hong Kong, they will disseminate the information on a flight informing tourists or visitors of the latest tobacco control measures in Hong Kong. At the airport, there will also be public announcements. So we will inform visitors in advance about the latest measures in Hong Kong so that they can arrive in Hong Kong with peace of mind. In terms of smoking cessation services, we have been very active. The DOH has a lot of different services, including free smoking cessation clinics as well as quitline. We also have a youth quitline targeting the younger generations. In terms of treatment modalities, there are different free treatment methodologies. We also have Chinese medicine acupuncture as a means to help smoking cessation. We have collaboration with different organizations to enhance efforts in this connection. We are glad to know that with the increase in the tobacco duty rate, there are quite a lot of inquiries about smoking cessation. The figures actually doubled. On the 31st of May, the World Health Organization had a no smoking day, and in the no smoking month in June, there was a marked increase in the number of inquiries, and we will ride on this trend to help citizens to quit smoking.
And in Hong Kong, across 200 points, including convenience stores and smoking cessation clinics, we have provided trial use of cessation drugs, providing 1 week of dosage. Of course, a nicotine substitute dosage can help, but it will take 8 to 12 weeks before the treatment is effective to help them quit smoking. So we're giving them a 1 week trial to experience how they feel after using it. And if they found that it can increase their confidence and determination to join the smoking cessation program, then we arrange for them to attend our free smoking cessation clinic to undergo the whole treatment. Chen Kin-po next. In principle, I support the smoking cessation measures, but tobacco control also needs to be encouraged. A broad brush approach will only have negative results. The Customs Excise Department lately has cracked down on illicit cigarette smuggling cases. I hope that they will keep up with their good work. For the non-smoking areas, well, you can't expect the venue managers to be responsible. Say someone smokes in a restaurant, you can't request the restaurant operators to ask the customers to leave. The staff there can only warn them, otherwise there could be conflicts. So the work should be left to the Tobacco Control Office, who can actually carry out more inspections so that the staff will not be caught in a difficult situation. I support increasing the age limit to reduce smoking among young people, but for the sale of tobacco products, well, actually, whether you smoke or not, it's best to make it a voluntary choice. So we should start with education to let people know that it's harmful to smoke. And should we adopt a broad brush approach? I think we need to be careful. And lastly, the consultation paper, I hope that it will be for real consultation. That is, if there are strong grounds expressed, then you should really follow them up. That's all. You don't need to reply or respond. I think before he responds, I and Chen Kin-po have been colleagues for a long time. I've never seen him talking. Actually, like what I'm going to say, so I don't need to speak afterwards, I think. Secretary, well, I need to be careful in replying. Firstly, we're having a consultation. It's a real consultation. We hope to hear public views, and we will actually adopt a very comprehensive approach. 4 strategies, 14 items. They will let us hear views from all sides, and also for various cities, regions in the world, the methods used actually are covered in the consultation. And the birth date, in some places, in relation to the issue of birth date in New Zealand, it adopts a policy that by 2027, they would, for those born after 2010, 29, they would not be allowed to buy cigarettes. We want to listen to the public opinions on this in relation to the issue of birth date. After the consultation paper was released, quite a number of people and the media have discussed this matter. We will listen carefully whether we should go for this approach. We'll look at the result or outcome of the consultation first. So I can reply definitely. If this is a doubt the chairman has, I'm sure that we will have a real consultation. Since you mentioned my name, well, there's time left for Mr. Chen's turn. I have seen lots of government consultations. I hope that we all have real ones. But what I wanted to say is that, as mentioned, I want to say what Chen Kim-po has said, but I want that in deciding whether to legislate or not, I hope that you can, before that happens, carry out an assessment. Just now, our colleague, Edward Leung, was asking whether this could affect tourism. So I hope that when you do the real consultation, and by the time it comes for you to legislate, you can assess, I don't know what it's called in Chinese, but what we mean is a regulatory impact assessment. That is, if you want to impose legislative controls, you need to do the assessment. The most recent case is last year, your bureau talked about e-cigarettes and heated cigarettes. Well, we were saying that even if you want to ban e-cigarettes, do you need to also affect our trade, export trade, goods exported overseas? And the Bureau went ahead and sought to adopt a moral high ground. But we've now noticed that lots of business have been lost in terms of cargo shipment and so forth. So I hope that you can carry out an assessment as well. You don't need to answer me, Secretary. Next one is Chen Wing Kwok. I welcome the consultation. On the whole, I support and agree with the government's four smoking cessation or tobacco control strategies. Whatever your policy is, if it's difficult to implement, then it cannot achieve your ideal tobacco control target. Now we've seen lots of people smoking in smoking areas, and most people would choose to just stay away from them and bear with it silently. If someone wants to make a complaint, the law enforcement officers cannot arrive at the scene in time. So I'd like to know if the government, when you implemented the policy, would you allow for the use of CCTV footage or videos captured by the general public as evidence, and that can be used as evidence to avoid people from smoking illegally. And also, smokers are willing to quit for the sake of their family, particularly if they have pregnant family members. So therefore, I think that the support of family members is very important for helping someone quit smoking. But in the government's policy of emphasizing education, you seem to have neglected the family factor. So would you consider providing consultation and training to friends and family members of smokers so that they can help smokers quit smoking successfully? Secretary? Thank you. As for the smoking in non-smoking areas and the law enforcement, in 2017, the Ombudsman has mentioned that we need to step up enforcement. Our understanding is that law enforcement officers cannot enforce the law at the venues. By the time the officers arrive, the illegal behavior may have stopped. So I'd like to stress that we would optimize the law enforcement process. But in a high-quality society, often behaviors need to actually be changed on the basis of a public consensus. Sometimes in issues relating, well, it's not just about law, like queuing up at a bus station, for example. No one would actually regulate the behavior, enforce proper cues by calling the police. So we need to have a culture in a society that people are willing to comply with the law. So I hope that in stepping up our enforcement, I will consider what Professor Chen just said, that we should not, we should not just use the videos, but I hope that I'd like to emphasize that the whole society can co-create a culture on tobacco control, because I hope that through the consultation, the public can understand better the harm of tobacco, that we can co-create the culture of tobacco control together, that we all know that cigarettes are harmful to our health. And all of us in public venues, even if we cannot get the law enforcement officers to arrive in time, well, we need to actually uphold the law. If someone smokes or take out a cigarette in the public venue, everyone should stare at that person. All the people at the venue should stare at that person. So we should co-create that kind of culture. As for smoking cessation, we support all means to support smoking cessation. We attach much importance to that because we hope that the present 600,000 people to quit. As for family members and friends, well, we have all kinds of education actually already, and we will provide support to family members who can call hotlines or go to our smoking cessation clinics to get support, appropriate support. Next one is Yang Wing Kit. I support a smoke-free Hong Kong so that Hong Kong can be more healthy and vibrant. For the fourth tobacco control strategies, they are good to me. But how do you balance various interests? I think that's something you need to think more carefully about. And in restaurants, or if you see someone smoking against the law, then you should call up the tobacco control office and to get the officers to come. I think that's what we should do. Of course, there may be a problem with the manpower, or the officers may not actually stop the behavior right in time. But I think we should step up our work so that we have a better environment overall. I think that for tobacco control, education is important, family is important. Like what Professor Chen said just now, my dad smokes, but my mother always educates my father. And therefore, our siblings do not smoke, and we hate smoking as well. And when I chose my spouse, well, I wouldn't go for someone who smokes. And that's the result of the continuous education carried out by my mom or my dad. So I think that family plays an important role. So whether in your publicity and other areas, you need to think about how you can enhance the effect of family influence. And just now, Professor Chen said something that I agree very much with. That is, how can you help the family members and friends in helping the smokers quit? We can think of ways. My mom's method was very simple. Just necking. Just keep necking day and night. But I hope that, well, not every family would go that way, but I hope that the government can think about it. Other methods like school education is also very important. When I was in school, my school kept telling us the harm of smoking, that smoking is hazardous to health, and they kept doing that. So for a long time, we had accumulated relevant knowledge, and we started to hate the behavior. You don't really need to stare angrily at someone who smokes, but I think there are good approaches out there. Publicity and reducing the incentives, yes, they are important. When I was small, I remember there used to be the Marlboro tobacco advertisements. When I was studying, all those advertisements were gone. So that really helped reducing smoking. Even now, when you buy a pack of cigarettes, I think this is something the government has to think about. Now when you want to buy a pack of cigarettes, people may have been used to it, the advertisement that is. So you may need to rethink your strategy. That is the content of the advertisement should be like that. The advertisement has remained the same, actually on the package. Do you need to make a change? For people in their 40s and 50s compared to the young generations, the thinkings are different. If you go for the old method, to the old smokers, they could have a deterrent effect, but to the young people, they may be a little affected. So I hope that the secretary, in your publicity, can be more creative and have new ideas. I'm very pleased to see that the secretary wants to target the younger generation, so to help control tobacco use. So I think you need to have new ideas, fresh thinking.
In addition, quite a lot of residents told me that they actually have very strong opinions about people who walk in the streets and smoke at the same time. You have to place the rubbish bins in suitable locations. Quite a lot of smokers actually go to rear alleys to smoke. Well, you said that you would just go on with one more sentence. You've used up all of your time. Well, Secretary, if you have to answer him, please give him a written reply. Thank you, Chairman. Next, Mr. Peter Shu. I also agree that there should be fewer smokers in Hong Kong. While Hong Kong has one of the lowest smoking prevalence rates all over the world, we also want to build mutual respect among smokers and non-smokers. In this consultation paper, well, maybe some people should not smoke while walking in the streets. Actually, most of the smokers go to the rear alleys to smoke. They do not affect other people, but then there are also people who do not consider others' feelings. There is room for discussion. But on tobacco control measures, they shouldn't be too extreme, as members mentioned. If you need to raise the tobacco duty rate to 75%, that is close to $100 per pack. Common sense tells us that $6,000 per month if a smoker actually smokes 2 packs of cigarettes per day. Well, actually, this will have an impact on illicit cigarettes. The cost of each pack is $10, but then the profit margin will be very great if one pack is sold at $100. This will give rise to illicit cigarettes, and this will only be detrimental to the health of Hong Kong citizens. If we draw reference from New Zealand, that is to ban the sale of smoking products after a certain age. Actually, the sale of e-cigarettes and heat-not-burn cigarettes are actually legal in New Zealand, but if we ban all these across the board in Hong Kong, then we will have nothing. There will not be any products for them. What about when a child turns to 28 years old or 38 years old? How can you restrict the liberty of people in Hong Kong, whereas other people in other parts of the world can actually smoke? We do need to strike a balance. We should strike a balance between freedom and the measures. Well, there are quite a lot of abhorrent advertisements in the pack of cigarettes. Well, I think this is actually an overkill. One cannot actually see the flavor of cigarettes if the advertisements are too large on the packing. Probably fruit flavor is better, and when they switch back to conventional cigarettes, the flavor is actually not that good. You need to do so in an appropriate situation, and you shouldn't take it to the extremes. When there is objection or disagreement among members, members actually mean that you should not take it to the extremes. Of course, I understand that the Secretary want good health for Hong Kong citizens. But let me ask you, ultimately, you want Hong Kong people to quit smoking at all. But are you actually just banning the sale of smoking products? Actually, 12% of the global population are smokers. Do you think that they will still choose to come to Hong Kong if Hong Kong is a smoke-free city? Well, I think you should consider this. Secretary, please give member a written reply. Next, Ms. Chen Hao-yan. Thank you, Chairman. Well, definitely, we support it when there are fewer smokers in Hong Kong. The Secretary mentioned four main directions in the public consultation. The DOH and the Tobacco Control Office have actually done a lot on tobacco control measures. You should have a very good understanding of the problem, and you should have come up with better proposals. For example, do the parents of the children in primary schools actually smoke? If they do, then they are high-risk families. You should target these high-risk families, and you can float a good proposal for locomotives. That is to say, for people who smoke while walking in the streets. We have quite a lot of complaints from residents or citizens in Hong Kong about this situation. This is actually harmful to the health of local citizens. But then you are just asking citizens what should be done in a public consultation paper. Should the government instead make suggestions instead of asking the public whether, well, what should be done? These are as easy as ABC. You should have floated different suggestions and asked the public which one is good, instead of the current method in the survey. There is also an increase in female smokers. What is the reason behind? Can you identify the reason? When you have identified the reason, the papers should target the reason and solve the problems. How can you ask the aged to quit smoking? This is a situation of the bottleneck. What we need to do is to prevent younger generations and females to quit smoking. We need to target them. It should be targeted. The panel on health services actually has 20 members. If each member asks 4 minutes, then it will be a total of 80 minutes. Well, I understand some items actually just pop up. Well, I think that members are actually inferior to reporters. We only have 3 minutes. Apart from panel meetings, there should be other platforms for members to ask questions. But then, for smoking or dentists, these are very major policies in Hong Kong, and members' views should be respected. Whether advance notice or post-meeting follow-up, these are not sufficient. And you should consider members' time while discussing certain topics. Secretary, thank you, Chairman. These are very important policies, and we understand that members have different views, and members may have a lot of different opinions on important matters, especially for this topic. Well, I mean, this panel meeting is the last one before the summer recess. We have been working very hard on all these policies, and we want to put in place all these measures as soon as possible. For tobacco control measures, our goal is to reach 7.8% of overall smoking prevalence by 2028. Well, I mean by 2025. For communication prior to and post meeting, we keep an open mind. We do not take a rest during summer holidays. Well, excuse me, Secretary. You have used up your time. Please provide written reply to member. Next, Dr. Dunslam. Well, Mr. Peter Shield, I will not allow the second round today. Please write to the Bureau should you want to express your views. Dr. Dunslam. Thank you, Chairman. As a doctor, I definitely understand the harmful effects of smoking, so I support all out that the administration should take a multi-pronged approach to create a tobacco-free Hong Kong. I support this all out. All of us have the right to choose, and we need to respect each other. How should we consider all of the people and put in place a policy that caters to the needs of different people? That is exactly why we need to tap the pulse of the community and different walks of life. The minimum wage of purchasing tobacco products is 18 years old in Hong Kong. But it seems that there is no minimum wage for smoking, according to some surveys. 2.3% of P4 to P6 students and 7.4% of secondary school students have actually tried smoking. They are the future of Hong Kong. Will the Secretary consider imposing a limit on smoking instead of just buying tobacco products? Next, secondhand smoking is one of the four main strategies. We should have the right to choose, but then for passive smoking, we actually have no choice. We are very innocent. Can you expand non-smoking areas to, for example, while on public transport or waiting for public transport, as there are quite a lot of children and ladies or females in these places. Thank you, Dr. Dunslam. Such contents are actually covered in the public consultation paper. I will invite my colleague to take this question. Mr. Eddie Lee. The sale of tobacco products to people below the age of 18 is outlawed. So the responsibilities actually rests with the providers. Children should not possess or should not be in a position to possess or have control of cigarettes. For places of high risk or places where passive smoking cannot be avoided, we will enhance our efforts. Thank you, Chairman. For people below the age of 18, you can just prosecute the father or mother of the child as to why the child has the access to smoking products. And the question is whether you will reduce the minimum wage of smokers or smoking. Well, I mean, the choice is in the person below the age of 18. The main point is that person should not possess or control the cigarettes or in control of the cigarettes. Well, I think possession is not a problem, but then smoking per se is the problem. Well, correct me if I'm wrong. Well, I'm just worried. If you bring down the age of the child, well, whom should you prosecute? This is only a public consultation paper. Well, Secretary, all our members have already asked all the questions. Let us move on to the next agenda item. The next agenda item is proposed amendments to the Dentist's Registration Ordinance, Cap 156. We have two papers, CB-4/695/2023/05, paper provided by the administration, and follow papers (06), that is a background brief prepared by the Legislative Council Secretariat. as we invite the administration in. Actually, all other members have been invited to join the discussion of this agenda item. Members, please press the button to speak should you want to speak. There should be 45 minutes for this discussion item. Ms. Chen Hao-yen, we will just allow 4 minutes to each member. You may not be satisfied. Well, for this topic, Professor Low and Ms. Elaine Mack, Deputy Secretary for Health, Dr. Kitty Te, Mr. Ronick Chang, consultants and principal assistant secretaries will join us. Thank you.
Thank you. I'd like to brief you on the proposed amendment to the Dentist Registration Ordinance, CAP 156, and to explain to you the background and the highlights for your discussion. And all along, we've been facing the shortage of dentists. And you can see that in the short run, the industry is facing an aging problem. In 2017, more than 45% of the dentists are above the age of 50. And by the manpower production in 2020, the shortage of dentists will be in the medium short term by continue till 2035. And in the public sector lately, the problem has become more serious. By July 1st this year, the Department of Health dental officers vacancy stood at 23.5%. And as the retirement exodus continues, the situation would deteriorate. If we cannot deal with the shortage issue properly, then this would affect our services in oral hygiene and dental services. And we also worry about the underprivileged, the dental health of them. In light of that, the chief executive in his policy address last year proposed that to ensure our public health system has adequate manpower, we will explore various proposals, including bring in qualified non-locally trained dentists. Let me stress here that locally trained dentists and healthcare workers will continue to be the most important bedrock of Hong Kong healthcare system. And Hong Kong has invested a lot of support and resources in supporting, in particularly United University Grants Committee, to enhance and increase teaching facilities for healthcare professionals. And in the past, for 4 times, they had increased the places for the dentistry program at Hong Kong U. From 2008 to 2009, 50 places, to 2022, 2023, 90 places. And because the training of local dentists takes time, and it takes 6 years to finish their education, and expanding Hong Kong U's dentistry program and expanding the Prince Philip Dental Hospital takes time. So we cannot just rely on local supply and increasing local places to ease the shortage. Indeed, in the past, non-locally trained dentists were the important source of local dentists. Before 1990, dentists, as long as they had overseas qualification, they could be registered for practice in Hong Kong. Back then, more than half of the newly registered dentists were non-locally trained. Later on, it's changed that the non-locally trained dentists need to go for a practicing examination. Figures show that in the past, only 10 to 30 people passed the examination, and that figure is not enough to meet the social needs here. Because of that, we think it's worth exploring, bring in a new pathway for admission of qualified non-locally trained dentists to cope with the shortage, particularly in the public sector. Due to the background above, the government is proposing to amend the dental registration ordinance. And also, in light of the industry's proposals made in the past few years, including improving clinical experience of non-locally trained dentists, and to expect the ordinance to cope with the latest changes in the profession. So our proposed regulatory framework has the following purposes. The first is to provide a new pathway through limited registration or special registration to bring in qualified non-locally trained dentists to serve in specified institutions so as to ease the shortage. And secondly, we want to have a temporary registration mechanism so that through the qualifying practicing examination and the non-locally trained dentists should need to go for a 1-year clinical practice, and after that can they be formally registered. And this is in line with the practice for doctors. And thirdly, we want to change the composition of the Dental Council of Hong Kong so that we can cope with the new changes. And fourthly, for 4 types of services provider, that is our dental hygienists and dental therapists, and we should provide for these 2 types of ancillary dental workers to enhance their regulation and to training to ensure their service quality. And fifthly, we should have continuous professional development and also to comply with the manpower projection requirements, and when needed to provide technical amendments so that the ordinance itself can move ahead with times. From February this year, the Department of Health and our Bureau have met with various dental associations, including our partners and also the dentistry faculty of Hong Kong U staff and students, and also ancillary dental workers associations, hospital authority, and various patient groups to consult their views on the changes to the ordinance. And on the whole, the various associations agree with the proposals for change. As for concerns that our locally, for non-locally trained dentists, dental graduates for the clinical service, we think that there have not been any objection, and I think we need to consider the appropriate time frame and for implementing the extended clinical practice period, and the relevant body is also willing to be a monitoring to play the monitoring role, and the relevant parties also agree with the arrangements. Based on the initial thinking of the Department of Health, our locally trained dental graduates and the non-locally trained dentists will be placed in various posts to receive supervision and assessment by registered dentists, including general dental services, for example, GP services at dental clinics, government general clinics, and also specialist dental services, for example, in elderly care homes for the elderly or for the handicapped people, and also school dental service or dental services in hospitals, for example, in public hospitals, the oral hygiene or surgical services, specialist services at clinics. And for the implementation time frame, it depends on the progress of legislating and consultations with various parties. So the practical arrangements cannot be launched this year, so would not be relevant to the students graduating this year. Later on, depending on the preparatory work, we will decide on the exact time frame. We hope to implement the latest requirement as soon as possible, and we also explore some transitional arrangements beforehand. We want to further listen to your views to enhance the proposal and to submit the amendments to LegCo before the end of this year. Thank you. So we've got 5 members who want to speak. Let me read out their names. Professor Chen Wing Kwok, Jovi Chan, Kingsley Wong, Chen Ho-Yen, David Lam. Professor Chen, please. Thank you. The serious shortage of dentists actually has affected protection of dental health of local people. So I support various ways to bring in qualified dentists so that the public can get appropriate dental care and services and to spare the pain of dental problems. So I hope the government can speed up your work and submit to LegCo your amendments to the dental registration ordinance. And in paragraph 26, it said that well, before actual practice, there need to be internship for the dental students. Now they study for 6 years to finish their training. So are they going to have their internship 1 year after their graduation or during their study period? Would this affect the current students doing dentistry studies because they may feel unease? Now they have their own career plan, and they now have to expect not to be registered until 7 years later? That is 1 year after they graduate. So can you give me the answer in relation to the time frame? Secretary? For the dentistry faculty, the program lasts for 6 years. The study is more about learning and not internship, and this is up to the autonomy of the university. Not what we're proposing now is an internship, similar to the current arrangement for medical students. That for the dental students, after they finish their 6 years of study, they will have a 1 year of internship in the front line in institutions and working for patients. And this can really actually help them, very useful training for them before they go into full practice. And actually, we proposed this to the Dental Council, and they said that whether for local graduates or non-locally trained dentists who've passed the qualifying examination to practice here, there's an urgency for implementing this internship, because under the current registration ordinance, once the non-locally trained dentists have passed the examination, they can practice immediately without the need for internship. So now our latest amendment proposal is what actually we have discussed with the Hong Kong U Faculty of Dentistry and DC Hong Kong. And we all think that there is an urgency to help our graduates and non-local dentists to enhance their clinical service quality. And this is outside the 6 years of learning. Okay, my follow-up question now. He was asking, so now we're talking about 6+1 training. Well, even with the institutional autonomy, the university has to figure out how to work it out. And with your amendment to the ordinance, would you provide a grandfathering clause so that who are now already studying at the dentistry faculty, they will be spared? Or is it that after legislation is passed, that's this next year when they enroll in the dentistry faculty, then they will be exposed to or subject to the 6+1 arrangement? And also for non-local dentists, they have been dentists for a long time overseas. Would they need to do the internship still in Hong Kong? Okay, even for non-local graduates, they actually may not understand, well enough the local situation. Even for someone, a doctor from the mainland who's very experienced, even when they pass the qualifying exam in Hong Kong, they would still need to go for internship in Hong Kong to understand the local medical system. So for non-local dentists, definitely they would need to be bound by the same concept that they need to spend time to understand the local dental system. And you can see of the full proposals, neighbors, we are giving them comprehensive training. That is, besides servicing in the dental clinics or school dental care or providing services in hospitals, they are going to have a comprehensive clinical practical experience. As for the implementation date, on the one hand, the DCHK agrees that there is an urgency to enhance local graduates' experience in actually coming to face-to-face with patients, because there's 6 years of training now, give them little exposure to practical experience. And in terms of the implementation, we need to think about the details. Therefore, we are now with DCHK and Faculty of Industry and Department of Health to consider the actual implementation plan. And that, of course, will affect the actual implementation date. Chairman, if you said that for all dentists or for all graduating students who have joined the profession, if they are to be exempted, that means we will have to wait 6 years. So we have some worries because DCHK mentions the severe urgency of giving them the internship. Yeah, I was just asking you about the government policy. Just now, Professor Chen said that some students who are now studying in the faculty, and now you're changing the rule of game, and that could affect their plan. So I was just asking you that.
Thank you, Chairman. I understand. We will liaise with the faculty. We will also listen to students' views. But this is very important to their professional development. Thank you, Chairman. Next, Ms. Zhou Chen. Thank you, Chairman. On behalf of the FTU, I had a motion in the council meeting. In Kuaiting area, there was a scheme in which we understood the situation about the oral health of residents. 70% of the 900 elderly people had problem with their teeth, but then they actually just bore with it because of the shortage of dentists. 60% of the interviewees think that the charge is actually too high. We understand that there is an acute shortage of dentists. Some 8 to 10% of dentists are not in Hong Kong right now. Does the administration have any statistics as to where these dentists are? Do we have any plan to troll for talents to attract these dentists to come back to Hong Kong? Will I support one part in the paper in paragraph 33 to 34? These are about to enhance the status of dental hygienists and dental therapists in order to plug the gap. Well, I have a further suggestion. Dental therapists are employed under the DOH. They mainly provide school dental care services to primary school students. I also benefited from this service for senior citizens when we have an increase in the number of dental therapists. Do we have the capacity to provide basic services such as dental scaling and dental checkup for elderly people in order to nip diseases in the bud? If dental therapists can work as such, then we can enhance their status as well as providing more services to people in need. Secretary, thank you, Chairman. Well, I agree with Ms. Zhou Chen. This way, we can increase the number of professionals, and we will troll for talents within the current legislative framework. Upon the amendment being passed, with limited registration or special registration, we will proactively consider going overseas or going to the mainland to hold recruitment exercises. And it all depends on the conditions after the amendments of the legislation, so that we will put in place measures appropriately. As for the future services to be provided, we will take a targeted approach to decide how we should chart our way forward. Will we provide, is there any dental service in the GBA available that can help us? These are what we are looking into. For dental hygienists and dental therapists, the amendments this time round also cover these ancillary professionals. We would like to enhance their professional status. They are actually formally trained. We want to consolidate their professional standards, quality, and status so that they can take up more duties to help more people. For example, as members mentioned, dental therapists should not be limited to the school dental care service under the DOH, but we need to see whether our manpower can cope with the situation. Next, Mr. Kingsley Wong. Thank you, Chairman. I speak in support of the proposed amendments to the dentist registration ordinance to to introduce more dentists. Dental diseases are actually quite painful. Dental diseases also lead to other diseases, such as digestive discomfort, etc. I hope the communication will be enhanced. There is a shortage of dentists. Even if we want to expand the scope of services, we still cannot. Well, we still do not have enough dentists. According to the current manpower projections, the shortage of dentists cannot be solved until 2035, and it will only become less significant in 2040. For newly registered dentists, 54% are non-locally trained. When can this situation be eased? Next, in March, the Hong Kong Dental Association made a visit to the mainland. We want the mainland to recognize the qualifications of Hong Kong dentists. Can we put in place mutual recognition schemes for both overseas, for both mainland and local dentists, so that they can practice in different areas? For registered dentists, apart from the DOH, they can also practice full-time in specified institutions. Are social welfare organizations actually covered? Secretary, on whether we have a timetable upon the passage of the bill. Simply put, we will not waste any time. We will not lose any time. There should be a vacancy. There needs to be a vacancy. As for NGOs, when there are vacancies, it depends on the number of vacancies we have and the number of talents we have. We want to enhance our appeal to attract these talents to return to Hong Kong. As for the timetable, the sooner the better. We will not lose any time. What about the benefits? Well, there are people who worry about many dentists returning to Hong Kong. One of the posts is to serve local organizations. If there are no such vacancies in local organizations or public healthcare system, then the recruitment exercise can be slower. On the mutual recognition between mainland and Hong Kong, the quality of dentists actually matters. Actually, the DCHK will perform its gatekeeping function well to ensure that the dentists coming to Hong Kong to practice is up to standard and up to a certain level. The DCHK will be the gatekeeper in this connection. For dentists in the mainland, what is their standard? What is their quality? For example, the years of practicum before they can practice. And we will also consider NGOs in relation to dental services. Next, Ms. Chen Hao-Yan. Thank you, Chairman. Dentists, the shortage of dentists has been a long-standing problem. There are a lot of vacancies under the DOH. They cannot be filled for a long time. Apart from the proposed amendments, what is your ultimate policy goal? After the proposed amendments, after the amendments, what enhancement can we see? Or are we just actually going to keep our status quo to maintain our so-called incomplete dental services? Well, we do not have a complete or all-round dental services at all. The general public sessions are actually emergency dental treatment services. Elderly people actually have no choice. They can only have tooth extraction or they can only take painkillers. Are we going to perfect our incomplete dental services, or are we actually going to see a marked improvement? For example, if I support school dental care services, will we see an expansion of these services to kindergarten students as well? Well, I don't think this is the case. There should be expectation management. That is the expectation of citizens for dental services in Hong Kong. We shouldn't overlook dental diseases. They do affect citizens in Hong Kong. They are no less serious. Well, there are just actually 10 odd dental therapists in Hong Kong every year. We need to increase the number of dental therapists. What level do we need to achieve in order to see an enhancement? In paragraph 44, dental hygienists and dental therapists can perform dental scaling without the supervision of dentists. What is the definition? If one is taking medications about heart diseases, there may be different situations, such as uncontrollable bleeding. If dental therapists have the qualifications to practice, then will it also lead to a hemorrhage of talents in this connection? Will this be a reason? Regarding the number of talents we can attract, we actually have regard to the vacancies in these specified institutions. The vacancies are not calculated on the current situation. For the school dental care service, it is the experts on the panel will make the decision. They will provide opinions to us. Ms. Chen Hao-Yan mentioned that we do not have a complete dental services in Hong Kong. Well, what do you mean by a complete dental services? It is impossible to provide dental services to the entire society. Well, of course, I understand that there are areas we can make improvements, but I do have a lot of reservation in this connection. For dental therapists, they do not have an independent treatment modality. They actually provide dental services with the supervision of dentists. Well, what do we mean by, what did I mean by a complete dental service? Well, civil servants actually have complete dental service. Well, You have already used up your time. Do not go beyond your time. For the topic today, we are talking about the proposed amendment instead of the policy itself. Don't waste any time. Next, Dr. David Lam. Ms. Chen actually means the services received, enjoyed by civil servants. Well, I heard from colleagues that when there are more dentists on practicum, we hope that they will not only serve civil servants, but they will also serve members of the public. On limited registration and special registration to attract or to introduce more talents to serve the Hong Kong community, in principle, I support this policy, but I do have some concerns. Apart from the Hong Kong U and other organizations such as the DOH, for limited registration, NGOs can also be covered. For those engaged for more than 5 years, if employers think that their performance is satisfactory, then they can be given registration. Well, I don't think satisfactory performance should be deemed a suitable condition. It should not replace assessment. Assessment can only be done by the DCHK. There is no other choice. But of course, the DCHK can engage consultants of the DNH, of the DOH to conduct assessments. But I fail to see any assessment capacity of NGOs. For dentists on limited registration or special administration, the DCHK should have the decision to require them to take the examination. This is to protect the well-being of Hong Kong citizens. To introduce special registration and limited registration, we aim to increase the number of dentists. But then citizens should be confident. And this is the principle of making good use of public funds. Can you ask the administration, is there any racial? We do trust universities, but there are cases at universities that there are matters in relation to professors, and there are also legal matters. I do not want to see such a situation with the NGOs. Well, I hope that members do not talk about any comprehensive dentist policy. This is not the main topic of this agenda item. Do not conjecture any members either.
I'm chairing the meeting. Don't make any speculations. Secretary? Thank you. Dr. Lam? On the assessment by employers, I think, by employers, we mean the Department of Health, Hong Kong U, Hospital Authority, Prince Philip Hospital, very clearly, and some would be specified by the Secretary for Health. Undoubtedly, they would be organizations providing substantive services. I think Dr. Lam would be familiar because he used to work in the public sector. Our assessment actually is not really about something that can be passed just by shoe shining. Our assessment actually is left to the senior colleagues within hospitals, and normally it's done by department heads. So I don't want to, have the public being worried that in the medical or dental profession, it's by shoe shining, and then you can pass any assessment. We actually abide by very stringent standards. So as for assessment by employers, well, it will be done by consultant doctors or department heads to make a decision based on the actual performance for a period of 6 months or a year. And if the assessment is passed within 5-year period, then the applicant may be spared an interview or demands from an examination. But ultimately, DCHK has the ultimate authority. But in determining the qualification of a dentist is really much dependent on the assessment reports while the dentist was in service, because DCHK cannot possibly send someone to monitor a dentist's work for a 5-year period. So DCHK has the authority, but its ultimate decision is based on the so-called employers' assessment, which is very professional. Well, sorry, Dr. Lam, you won't have a second round. Next one is Dr. Dennis Lam. Thank you. Let me declare my interest because the company I work for provides dental services in Hong Kong. The latest amendment proposal, I welcome it and I support it. Because if, given a shortage of dentists, well, we need to address it. And besides dentists, the therapists and so forth, they are actually part of comprehensive service. So I welcome the proposal. I've got one question. That is, you said that there should be an addition of 1 year internship after the completion of a 6-year program. Well, right now you don't need the internship to practice as a registered dentist. Well, I welcome the change. I have been operating the related service. I know that when someone, for a fresh graduate to go into full practice immediately, for the dentists and the patients, this would have negative impact. I've got a question here because in Hong Kong, on the whole, most dentists work in private clinics. So now, with the amendment, do you think there will be adequate internship places? So I hope there will be adequate places. Based on your proposal, the graduates will need to work in public clinics. So if there's not enough places, then would you consider selecting some private clinics to have cooperation with? Because in private clinics, we've got some PPP. They're running PPP model. That is private-public partnership model. And the internship emphasizes, the actually getting a clinical experience. So for non-local dentists with huge or much clinical practice experiences, then do they really need to have internship for 1 year? Now we're faced with a shortage, so that they do need to be familiar with the Hong Kong situation. But should they be bound by the same period, 1 year internship? Secretary. Thank you, Dr. Lam. On the 1 year internship, this is what DCHK proposed years ago due to the pressing need. And in the latest assessment, DCHK, with Hong Kong Youth Dental Faculty, with discussions, they think that 1 year internship will provide important help to our graduates. Because DCHK is a statutory body in Hong Kong, it does have the authority and ultimately the responsibility to assure that our dentists are actually qualified, really qualified. And for internship, we really have to arrange for it as soon as possible, whether it's the DCHK or the Dentistry Faculty of HKU and also Department of Health. They have begun work on it, including, as I said, actually looking at 4 types of services to arrange for appropriate internship opportunities for graduates and non-locally qualified dentists who have passed the examination, so that they can not just through the word to be familiar with the overall dental situation in Hong Kong and to have more experience, clinical experience, and that can also help with assessment purpose, because for non-local dentists, we hope that through the 1 year internship they can be assessed again. And so this is really in line, of course, with what we have in mind for dentists here. Next one, Elizabeth Kwok. I speak in support of the amendment proposals because it's very important. I've often said in Legislative that we need to bring in more dentists. Now, in Hong Kong, we only have 0.37 dentists for 1,000 people in Hong Kong. We are really lagging behind. And now we have aging problem among the dentists. If we don't have new methods to bring in more dentists, then we cannot solve the problem. So importing qualified non-local dentists is one solution. I'm also worried about a 1 year internship, however, because you need to have adequate places. Now you're expecting them to practice in the public sector for 1 year. So you do have to have adequate places. And secondly, I want to know about for a qualified dentist, from overseas who are to have internship for 1 year here. How about the income level during the 1 year period? And compared to the income after the internship, would there be any difference? Would the payment during internship be so low that they would not be attracted to come to Hong Kong at all? So I'd like to find out about it. And also like to know, the government, when you are trying to attract more dentists to come, how would you attract them? Will you carry out road shows? What is your target? Where would you go to attract dentists to come? Can you show us your plan? And lastly, in the coming 2 years, how many non-local dentists are you expecting to attract to come here? Secretary? Thank you, Ms. Kwok. On the non-locally trained dentists, once they have passed the licensing examination, based on their qualification and their experience, well, if they have practiced overseas for a long time and have some specialist qualification, then DCHK could actually minimize their internship period or shorten the period. As for their pay, once they've passed the examination and if they go on internship, of course, their payment will be in line with what's offered for internship. But after they finish the internship, they will be a fully registered dentist, and then they can work the way they want. So this is, actually similar to the arrangement or the same as the arrangement for doctors, medical doctors. As for the number, for question 2, number. Well, let me stress that ultimately, based on the public organizations like Hospital Authority, University, it's our initial estimate that we hope that we can fill all the vacancies because they must have vacancies. But later on, what the services in the future will be like, whether we'll add more vacancies, well, that will depend on the decision of the working group. For the vacancies, well, once the vacancies are filled, of course, they would not be asked to come. What are the number of vacancies now? Department of Health has got 87 vacancies now. So at least you need to fill up the 87 vacancies first. Once they are filled, whether we would, depending on the proposal or report of the working group, to expand it further, we will make a decision then. But let me stress one point. In the future, where will we go to attract talents? It will depend on the DCHK's proposal, the requirements for limited and special registrations. Because for medical doctors, we expect them to be graduates of medical institutions. There are now 100 of them. Well, more than 30 are actually British courses. So But for dental graduates, what kind of criteria would be proposed by DSHK is up to them, and we will wait for their professional requirements first before we come up with targeted recruitment work or plans. Well, sorry, Ms. Kwok, your time is up. So you have repeated that you support the amendment. Secretary, the Liberal Party supports your amendments, but your proposal to bring in overseas dentists and to expect them to go for such a long period of internship, we're worried that that could undermine your recruitment effort and the number of overseas dentists who are willing to come. But of course, we need to strike a balance in ensuring their skills, and of course, we hope that when the time comes for the legislative process, I hope you will not. We don't want to see it like in the case of doctors, for you to, actually discourage overseas dentists from coming.
We have finished this agenda item. Let us move on to the next one. Chronic Disease Co-Care Pilot Scheme. We welcome the administration to join us. CB 4695/2023-07, the paper provided by the administration. And there is also one other document, CB 4707/2023-01. Members who wish to speak, please press this button. As I mentioned, we have guests coming to join us for lunch, so I have to manage the time well. We will have to close this agenda item by 12:45. With us today are Dr. Libby Lee, Undersecretary for Health, Mr. Eddie Lee, Deputy Secretary for Health, Dr. Pang Fei Chow, Commissioner for Public Healthcare, Commissioner for Primary Health Care, Dr. Zheng Wai Lun, Director of Strategic Purchasing Office. Thank you, Chairman. My team and I are glad to introduce to members the Chronic Disease Co-Care Pilot Scheme. Since last September, we released a primary healthcare blueprint. This is the first item. President Xi mentioned that we hold the first responsibility of our own health. We should be held accountable for our own health. We should also support others to protect the health of their own. In this scheme, we invite citizens who do not have hypertension and diabetes to take part in this scheme. 17 people per 100 people are not aware of the fact that they have these diseases. The Co-Care Pilot Scheme aims to identify these two types of people. For those aged 45 or above, can go to the DHC to register and to have screening checks. They can also arrange for blood-taking checkups. Citizens only need to pay $120 and do not have to pay the laboratory for extra. The government has actually subsidized $192. If patients have high blood sugar and so on, then we will provide different services, including life course preventive care to citizens. For charges in this regard, I will talk about it at a later stage. For the Co-Care Pilot Scheme, apart from helping patients to deal with chronic diseases, it actually helps the community on 7 different fronts. to conduct health risks to support different patients. In the long run, the DHC will provide different services such as life course preventive care. Next, for the Family for All concept, all citizens taking part in this scheme can choose their own family doctor on the register through the DHC. They can be matching. Next, on the multidisciplinary healthcare system, we would like to promote healthcare professionals to provide primary healthcare services in the multidisciplinary mode. Apart from family doctors and nurses, allied health services where professionals will also render assistance. Co-care pilot scheme introduces a bidirectional referral mechanism. If need be, 7 clusters will set up designated medical consultation arrangements, and there will be consultation referral services. Patients will be referred to their own family doctors for further follow-up. Next, incentive scheme. We have put in place a doctor-patient partnership incentive mechanism to encourage them to monitor their health, better manage their health, etc. They can receive a maximum of $150 of reference co-payment amount, and the doctors will also receive a payment or an amount. We will set up a register. The Strategic Purchasing Office will also help in this regard. They can provide discounts to medication suppliers to purchase medications on the register. Patients can then receive subsidies by the government in a co-care scheme. Medications of chronic diseases are covered, such as, and other diseases as well, such as flu, influenza, cold, etc. For the subsidy, it is $103.50 per quarter. In the future, we have plans to expand the coverage of medications. In the phase of treatment, doctors can actually set the fees at their own will. 150 plus 160 plus 103.50 cents, as well as the incentive of 15% of the doctor-patient partnership incentive. We anticipate that the doctor will receive a total of $430. For a diabetes and hypertension patient, we believe that this amount is attractive to doctors. Doctors and patients will have to agree to joining the e-health. The government will take this opportunity to update the system to support the treatment mode, including the matching of family doctors and patients, as well as clinical record, to move towards a concept of one health concept for all. In September, we will announce even more details about the co-care scheme. Now, my team and I are happy to take questions, and members take questions from members. We have 30 minutes. There are 10 colleagues waiting to speak. Seldom do I draw a line, but after these 10 members speak, it is impossible for me to allow further members to speak. Question and answers, 3 minutes. Mr. Chen Pui Leung. Thank you, Chairman. I have a question. We have a shortage of medical healthcare professionals in DHCs. There is only one nurse station in each DHC. I'd learned from patients that when the nurse is on leave, then all the appointments will have to be called off, and the follow-up will take a longer time. For the CDCC pilot scheme, how can the government make sure that the DHC will be sufficiently staffed to support the patients? There is no doctor in the DHC in the long run. Will you introduce more doctors to the DHC? On the community medication register, are the contents the same as the drugs register published by the DOH? Are they the same? Will there be great differences? For diabetes patients, every 1 to 2 years, there will be a complication risk assessment. It is free of charge in public hospitals, but it takes quite a long time to wait for the assessment, some 2 to 3 years of time. When the pilot scheme is introduced, will the waiting time be shortened? When the laboratory services are contracted out, will the patients have to bear the cost? A lot of them are retirees. Will they be asked to bear the cost? I will take some questions, and I will also ask Dr. Zhang to take other questions. On the manpower in the DHC, the Strategic Purchasing Office wants to introduce a purchase service in the DHC in order to release the manpower load. Through the co-care pilot scheme, we will match patients with doctors so that patients do not have to wait further in the DHC. Next, on the complication risk assessment, at this stage, we actually target yet another category of patients, that is those above 45 years old and they are not aware of any diseases of diabetes and hypertension. Dr. Zhang, please be succinct. We want to have a system so that we can purchase medications from suppliers of the DOH to solve the problem in relation to medications, especially for the higher cost of chronic disease medications in the private sector. This will be very helpful to the system as a whole. Next, Mr. Yang Wen-kit, Deputy Chair. Thank you, Chairman. First of all, I support the CDCC pilot scheme. There are a couple of questions that I'd like the administration to answer. First, the targets are 45 years old or above, and those who are not aware of any diabetes or hypertension. But as I understand, a lot of elderly people above the age of 60 will be made aware of any diabetes or hypertension. For those above the age of 45, usually when they have checkups, they do know that they suffer from diabetes or hypertension if they do have. So how can you actually attract this category of people by paying them $150 so that they will join this pilot scheme? Or actually, rather, they can still join the scheme after the checkup when they are made aware of the diabetes and hypertension. Next, about the subsidies, $103.50 per quarter. You can sponsor a maximum of, subsidize 6 consultations. So that is $69 each. So patients can have follow-up once every 2 months. Will the medications prescribed last the two months? Elderly people actually take several tablets of hypertension medications. Can this amount last the medications for 2 months? Well, I don't think we should do the calculation this way. Thank you. Undersecretary, for those aged 45 years or above who do not know that they have hypertension and diabetes, the population is 2.2 million. We will enhance publicity efforts, and we hope that there will be more participants. But I have to make a clarification. For screening, the cost is $120. We want more participants to come and join the screening. They only need to pay $150 when they identify the physical conditions or the diabetes and hypertension conditions after the checkup. We have discussed with the relevant organizations, and we find this amount attractive. On medications, whether they are sufficient, it depends on the procurement price, and that is exactly why we have this strategic purchasing office. We want to purchase the medications in a centralized manner or in bulk so that patients can enjoy a lower price. In fact, we have drawn reference from different PPP schemes. That is those under the hospital authority. We have drawn reference from these schemes.
主席，
It is a support. I basically support this chronic disease co-care pilot scheme. I'd like to point out that, well, Secretary, now you only cover HT and DM, and you said that many people may have this disease and yet are unaware of it. But would you consider osteoporosis? Because women, well, actually, many women have this problem, osteoporosis. Well, maybe men have it too, even though to a less extent than women. Because often when an old person falls and they have bone fractures, only then would they realize that they have osteoporosis. So people's awareness of this condition is very low, and yet there's no such screening, for that condition. So would you consider osteoporosis later on in your scheme? Because someone who breaks their hip, that could affect their whole quality of life, and hospitalization costs a lot. So to the public or the medical system, if the screening could cover osteoporosis, then that can allow someone to be aware of the condition first and be treated first, and that would be a good thing. Would you consider covering it in the scheme? Undersecretary? Thank you, Ms. Kwok. Not just osteoporosis. We have received information from a number of people who want other chronic diseases to be covered by the scheme. I think it depends on how many people are afflicted with the condition and so forth. We have an open attitude. For example, hepatitis, we consider including it in the scheme, but we're now at a starting point only. So we want to cover the most common chronic diseases, which are HT and DM. But osteoporosis, well, you don't have the figure. You don't know how many people are afflicted with it. So that makes you think that not many are affected by it, but we know that worldwide figure shows it is a common problem. And now with aging problem, many women are faced with this condition. We have seen these problems a lot in the community. So I hope that you can see that this is an important disease to be covered. And also now, well, for first assessment screening, you pay 120. We have to pay 120. That's quite a lot. Would you exempt families who are on CSSA or who are on OH living allowance so that they will be encouraged to take part in the scheme? Thank you, Ms. Kwok. For families who are impoverished, well, what we need to consider is we need to align with the general clinics of hospital authority, because we hope that under the co-care pilot scheme, we want to get the patients to take responsibility for their health. For patients who are actually not so well off, so they would need to be subsidized. So our next step is to discuss with the general clinics to see what is the pricing level that we should set. Next one, Chen Kim Po. Of course, we agree with the approach of early prevention, early treatment. And for the scheme to be successful, patients, doctors need to take part. Just now, the Undersecretary says that, well, you believe that you are providing enough incentive to the doctors. I'm not worried. But for public participation, you said that it will depend a lot on publicity. But to me, I don't think it's that easy, Because for people without any sign or symptoms of disease, then why would they be willing to pay $120? So I hope that you need to see if it's not so popular, then you need to think of other ways to provide more incentives. And my second question is for collective procurement. I know that procurement cost is low for hospital authority, so can you maybe incorporate your scheme to the hospital authority's procurement so all the bills be paid together? Okay, Undersecretary, well, I will answer the first question first. Thank you, Mr. Chan, for your view. Yes, we care a lot about how the public are going to feel about the scheme. Besides widespread publicity for district healthcare centers, they would need to take the initiative to reach out to people in the community to join the scheme. And we'll also make arrangements in our contracts so that the centers would find a certain number of patients to join the scheme so that the message can be spread further out in the community. As for medicine procurement, I will ask the Dr. Zheng to answer. In formulating the community medicine register, I have actually will try to get low-cost drugs. You've asked whether the $103 per quarter is that feasible. Actually, in the future, for doctors, for drugs that they can procure, for 97% of the drugs, they will be less than $1, and the rest will be less than 30 cents each. So I'm sure that we'll have enough to pay for 1 year of drugs. Next one, Lam So Wai. Just now, the Undersecretary said that people who are aged about 45 and yet unaware of having HD and DM, they number about 2.2 million. My understanding is that the district health centers, they will try to identify some hidden patients. But I know that the district health centers have heavy workload. So would they have the manpower, or how are they going to be able to attract that many hidden patients to join the scheme? I'd like to ask your view on it. I really have doubts because district health centers are actually providing all sorts of services, and some centers have told me that they have difficulty coping. And also for chronic disease patients, organizations, they've told me that the co-payment, about the co-payment proposal as asked by a colleague of $120. Well, I want to get some clarifications. Under the scheme, for these patients who have go for screenings time after time for several times, would they need to pay, not have to pay later? Would you stop doctors from charging the patients extra? And also for the community medicine register, just now it said that, well, the hospital authority now is setting up a register, relevant register. How about your workflow, your work progress right now? When will it be launched? And also for private doctors, for diabetes, maybe the drugs used by or dispensed by hospital authority and those dispensed by private doctors may be different. So will all those drugs be covered under the scheme? I'll ask Dr. Pang to answer the first question. But let me say something here first. For the co-care pilot scheme, there will be a clinical guideline included as well. We have various specialists and also family doctors who work together to devise the guideline. That is under what conditions should the case be referred to specialists. We have medical guidelines. So for the doctors, patients joining the scheme, they will need to be treated according to those guidelines. As for the co-payment, I'll ask Dr. Zheng to answer. Dr. Pan can explain about the situation of district health centers. Thank you, member, for your question. For district health centers, under the current scheme, well, we are trying to attract patients, not just through DHC, but also through private clinics to carry out matching. So our contact points are not just district healthcare centers alone, but of course the centers would reach out to the community. And also we would actually work on procurement, and so that they can take part in it. And in the current work, well, they actually do have contact with DM patients, but we will improve their efficiency, work efficiency, so that for the support for GPs and repeat consultations can be more effective. So you may have to give your answers in writing. Sorry. Dr. Chen, could you give us your answers in writing as well? Next one, Dr. Tam Yu Hung. Thank you, Chairman. I support this scheme, pilot scheme. My question is, in 2014, launched the PPP scheme, and the residents who are joining the scheme for screening, after they are diagnosed with chronic diseases, can they continue to join the PPP scheme? If they cannot join the PPP scheme, then the subsidy for PPP scheme is quite a lot. But if the patients can join both schemes, for those who are diagnosed with the condition, and yet if they cannot join the pilot scheme, would that be unfair? For the pilot scheme, it targets patients or people who have not been diagnosed. Does not include those who have already been diagnosed. So for those who have been diagnosed with DM or HT and yet are not eligible to join the PPP scheme, what would they do? What are the methods? Undersecretary, Dr. Tam or Mr. Dr. Tan raised a good question. Let me tell you our long-term plan. And okay, well, maybe can you finish in about 1 minute? For the long-term plan, we hope that through a step-by-step process, the PPP scheme can be incorporated into the framework. We'll do it step by step. The first step is we'll tackle those without disease. The second stage is, if possible, we would bring people already diagnosed to join the scheme and seek help in the community level and join our DHC. Dr. Zheng, for PPP scheme is for people. Well, for this co-care pilot scheme is for people who are not aware of any conditions. Once they are diagnosed with the diseases, they can remain in the scheme to get treatment with government subsidy. Under the hospital authorities PPP scheme for general clinics, they are for patients, existing patients. So, and the HA patients who have been seeking treatment for 1 year, those patients can join the PPP scheme. So those two schemes target at different people, different types of patients. In the long run, we'll see how the two schemes can be merged. Next one, Chen Hao-Yan. I've got several questions. Firstly, for this scheme, it is a pilot scheme. How long will this scheme last? Because people have been talking about its attractiveness, the cost, the payment. So we need to do a review after all. So when will you carry out a review on the scheme? And there may be a need to, depending on the situations, adjust the payment as well. And also, secondly, you're collaborating with GPs, and I learned that sometimes the GPs may, because of the disruption in supply of drugs, for example, like in the case of antibiotics, they cannot get the drugs. So when they write place the order with pharmacy, and the price of the drugs order may be different from what the government can provide. So also under the pilot scheme, would you in the long run incorporate Chinese medicine practitioners? Thank you, Ms. Chen. Well, this is a pilot scheme for 3 years. And under this scheme, we expect this scheme to be reviewed. There'll be 2 layers of scheme. The first layer is internal scheme to look at the figures, the response, the market situation. And the second layer of review will be done by universities. That is, in the long run, a co-care scheme. How much impact does it have on the community health? For the community pharmacy, I will ask Dr. Zhang to answer. And for Chinese medicine practitioners, for this co-care pilot scheme, yeah, this is based on Western medicine. I know in Chinese medicine, it's more on comprehensive, holistic care, and also preventive care. So therefore, we'll consider for chronic diseases the role of Chinese medicine practitioners. Well, for this pilot scheme, we cannot include Chinese medicine practitioners.
用咗
Dr. Chen, please. We have used the medication supplier from the hospital authority. There are quite a lot of limitations. The supply is rather stable. For the community medication register, whether it can be expanded to community pharmacies, we will need to look into this. We have already started looking into it. In due course, we will consult members. Any follow-up? No. Next, Dr. David Lam. Thank you, Chairman. Does Dr. Zhang know that we have a shortage of a particular medication? There is no stock of this kind of medication. For my case, for pre-diabetes, some situations are quite tricky. If you want to manage the situation well, the patient might not be able to bring the situation under control even when the patient limits the food intake. The 4th, 5th, or 6th kind of medications are not available on the register. They are not quite new medications, so to speak. Do you have a regular review instead of an ad hoc review if need be? When will you enable non-members of the DHC to take part in this scheme on the co-payment and the subsidy scheme of the government? Honestly, the government has not started any review. For example, for colon cancer screening scheme, there wasn't even once in 7 years, and I believe that it is necessary to have a review. For chronic diseases, actually patients have trust in doctors. For example, when we sprain our ankle, we prescribed antiseptics and antiseptic injections. I'm not going to prescribe another medications. Instead, I prescribe ointments, and the price is actually over $200. If the patient is from the CDCC, is it the case that I cannot use these medications? There are quite a lot of conflicts or contradictions. I'd like an answer from the administration. On medications on the register, I will invite Dr. Zhang to take it. And I'd like to talk about the DHC, whether non-members of the DHC can use the medications not on the register. Well, actually, we want DHC to provide services for members. Actually, DHC provides services other than medications, including changing one's life patterns, other screening checks, as well as programs like life course preventive care. A lot of documents or literature show that we cannot just rely on medications for chronic diseases. So, to change one's life patterns is at the top of the agenda. That is the most important. Provide a written reply, please, Professor Chen. The CDCCP to identify diabetes and hypertension patients, I think that this is actually a very good scheme and I support it. But for the subsidy level, well, I think it is actually open to discussion. In the course of screening, patients have to pay $120, subsequently $150 per consultation. The charge is quite reasonable. But for outpatient clinic, $135, and for subsequent follow-up, $80. These charges are therefore quite high. Some citizens may not be willing to take part in this scheme. So for citizens on CSSA, can you provide any exemptions, or can you provide a better price? Every quarter, $103.50 subsidy will be provided to doctors. Doctors think that the subsidy is actually too low. They think that the government is tightening its belt. Do you think that doctors' intention will be undermined? Is there any room to increase the number of, the price? And this will also make doctors not use better quality medications. Thank you, Professor Chen. Dr. Libby Lee, please. Where the economic situation does not allow, we want patients to stay within the safety net. Professor Chen also admits that this is actually quite a good price. It is quite cheap indeed. If patients are on CSSA and want to take part in this scheme, we do welcome this kind of patients, but I want them to stay within the safety net. Overall, we take a look at the procurement price of medications. Through centralized purchase, the price of medications are actually cheaper. This can benefit patients, so we do not worry in this connection. But we do have a review mechanism in terms of the charging mechanisms and medications prices. For some registers, patients may have to bear co-payment price. So we will move towards this direction in the long run. The Liberation Party actually supports this scheme. For other diseases such as osteoporosis, will you cover this as well? We have already finished this agenda item. Next agenda item, any other business? There being no other business, meeting adjourned. Thank you.